I'll just be quick because once you don't have substance, you take help of memes, cartoons, and everything. I'll only use them to substantiate few obvious facts, and we'll stay away from the fiction because end of the day, this is a scientific conference. So why my prone friends feel that prone is better? I would just tell them that when you have so much more you can do in the same patient and you have much more options, why we are being limited? So the prone people think that they are trying to fix supine PCNL. There is nothing to fix. Neither supine is there to fix what is lacking in prone. It is an entirely new dimension which opens up much more opportunities to treat your patient in a correct way, respecting the patient as well as the kidney. When prone proponents, they want to show prone better, PCNL better against RIRS, they will use same arguments, time, cost, this. When same thing is posted, when supine is even better, no, this is how I do. So this is how I will fix you. So don't try to fix your patient. And respecting kidney is most important. What is the dilemma of the prone proponent? Why change? I've been doing 50,000 PCNL already prone, so why I should change? That's the biggest dilemma. And there are not much learning opportunities actually for the people who actually want to learn supine. So you can see in this conference only one case is happening. So what happens with the dilemma? There are early conclusions and we want to quickly prescribe it to everyone. Everybody was taking hydroxychloroquine and now the person prescribing is gone. So what is the problem with data? The prone proponents have so less data to pick it up because there is not enough. So they will pick it up with like a pinch of salt because only that much they have to pick. There is nothing more which actually favors today prone over supine. They are entirely missing the point. They are trying to prove that prone is a very natural way of doing thing. It is not a natural way of doing thing because you have to position patient twice and you have to, that increases your time duration. So you don't have to take a longer path. The other problem with prone is that we have already learned prone. Now, after learning something which comes with so much difficulty, it is very difficult to switch to a new modality. So there is obviously a inhibition in terms of learning something new. And it is easy to presume that all anesthetists are happy positioning your patients prone. Maybe anesthetist is your wife, but I don't think, because I have done a survey in all more than 150 anesthetists. And these are the results, what is their preferred anesthesia position, how they will like to manage their patient. So we should think about patient and we should think about the anesthesia aspect as well. The COVID time, prone positioning, better ventilation is for the awake patient. It is not for the anesthetized patient. As the patient is anesthetized, the abdomen is compressed, the diaphragm goes up. It doesn't, anybody has to really become a doctor to understand that. All cardiorespiratory parameters are better in supine or oblique supine position. This is not a new fact, this is a Miller textbook of anesthesia. These things do happen. Just be thankful to God if they have not happened to your patient. Or maybe we are not looking that way whether our patient, what happens to them. So I'll just, this is also one more they have all shown very horrible complications. With PCNL, this happens, that happens. So there is a case with prone PCNL, subconjunctival hemorrhage, even to degree of transient vision loss. These are the documented complications in prolonged prone position. Patient has come for a simple stone removal. Patient has not come to get this acupressure therapy. There are so many pressure points which you have to secure in terms of, and one very important issue which is much more properly seen in a Western context, the hypothermia, all the fluid which is falling, it falls over the patient when we are doing prone PCNL. While in supine, all the fluid falls away from the patient, the chances of hypothermia is less. Bleeding, infection, this is all pure data which shows all these complications are much less. Urinoma, sepsis, they are less in supine PCNL because there is less intrapelvic pressure. And prone PCNL, they defend the same thing against RIRs by saying that PCNL has lower pressure, while supine PCNL has even lesser pressures compared to prone PCNL. colonic injury. It's just a fear which is instilled in the mind of the people. There is no increased risk of colonic injury. In fact, theoretically, the chances of retrorenal colon are much more higher in prone position. So obviously, in obese patients, while we are preferring PCNL over RIRS over anything, the supine PCNL is much more convenient for obese, for respiratory disease, elderly patient, motor neuron disease, patient with cervical issues, spine issues. And we are, in general, as a surgeon, we don't value our quality of life much. Sitting on a robot is fancy. It costs $2 million. But to sit in a supine PCNL, you don't have to spend that much. You can comfortably do your surgery. Radiation exposure, again, like previous speaker said, nobody wants to address the elephant in the room. It is a very important factor for the surgeon's risk of developing any malignancy. And you see in the supine position, almost 3 feet away, surgeon sits. I have not seen a single demonstration of prone PCNL while doing puncture or dilatation. Surgeon's hand have not come in the way of radiation field. And nobody would want that. Spontaneous stone drainage, of course, once in prone, they will say that we can do suction with that. What the God has already given a very good thing, gravity, which helps. Why you create another machine to do the same thing? Versatility. So they are trying to say that supine, you can't do this, you can't do that. Most of the people who are saying that, they themselves say it needs 100 PCNL to learn a prone PCNL, but themselves not even doing 20 and jumping to the conclusion that it is not good. No, I can't do it. So one has to do enough cases. There is, of course, a learning curve. Multiple calycial access, superior calycial access, anterior calycial access, which is very difficult in prone, and endovision assisted puncture. These all are possible. Maneuverability, moving from inferior to superior calyx, superior to inferior calyx. It is equally reciprocable in supine position, much better compared to prone position. ECIRS. Now the first debate would not even existed if we were only doing supine position, because ECIRS or the combination of RIRS and PCNL is much easily possible with the supine position. Now obviously the prone proponent will say that we can do ECIRS in prone also, but they have only seen it in case reports. They have not done themselves. Staghorn and ECIRS, of course, it is a much favorable situation for better stone clearance, and it can be your savior. Migration of a stone, difficult RIRS, a stone moves into the kidney, just tilt the patient a little bit and take out the stone. Patient's quality of life is important, surgeon's quality of life important, and so is the quality of life of his staff. If I show you this patient, if anybody can turn this patient with 150 kg, if he can be turned with less than 6 people in the OT, he should be awarded. Only 3 people needed, one anesthetist, one surgeon and one assistant. Hospital services will improve because you will save time by doing supine position. Cost. These are the fancy Montreal mattress. You know, it comes from the name from the place it was invented. It is specially designed for prone obese patients, for putting them in prone, because it is so dangerous to put them in prone. I have not seen this mattress anywhere in India, anybody using it. And of course, you need endotracheal tubes which are reinforced. Cost of draping patient twice, and everything adds up. Cost of forceps, I don't use even forceps once to retrieve the stones. OR time is money. OR time is saved at every step. You save every second to save hours. You save every penny to save millions. So the anesthesia time is saved. You can give spinal much easily. Positioning is faster. Single painting draping is needed. Quicker drainage of stone. Quicker patient turnover. And it is very difficult for proponents to accept the obvious. But this is the data I am showing. We have done a survey on a Facebook group of 8,000 people. Over 80% surgeons, urologists, who are under the age of 45 are already doing it. So if you are not doing it, you are already missing the bus. If you don't realize, you will be oblivious like the above 3 brands. Thank you so much.